On the theme of innovation, I thought I would take the opportunity to tell you a little bit about our new healthcare professional tiered service. Clearly, it's absolutely vital that we make the absolute very best use of our frontline, treble line vehicles and our highly skilled paramedics to deliver care to those patients that have critical needs, and in particular that need specialist care en route to hospital. We know that is hugely important. But we recognise that from our healthcare professionals, from our GP colleagues, we know that about 30% of patients that do need a same-day assessment in hospital actually just simply need to be moved in a timely way, but don't actually have specific in-transit care needs en route to hospital. We know that some patients will require monitoring, but no other specific intervention. And we recognise that about a third will need a paramedic. And one of the processes that we've introduced within our clinical contact centres, which are becoming increasingly clinically sophisticated at prioritising the way that we send out our resources, we're now using a much more clinically sophisticated tool that determines not only a clinically appropriate time frame for which people need to go to hospital, but it makes an assessment of their mobility and their clinical needs. And that's enabled us to dispatch other clinicians other than our paramedics in order to safely transport patients to hospital, which is a good thing because it then leaves our precious resources for those more complex and timely emergencies. This is clearly a good, cost-effective and responsible way to be configuring our services. I'm a consultant in emergency medicine, continue to practice clinically, and clearly one of the things that I have absolute visibility of are the risks that occur to patients, particularly when the emergency department is busy, particularly when there are surges in demand, and because of the very real potential for patient care to be compromised, particularly if there should be any significant handover of care delays for individual patients. And those patients represent high risk. So that's been a major area of focus for us, and we've recognised that there's been quite a lot of variability within the South Central in terms of individual hospital performance, in terms of being able to reduce unnecessary ambulance handover delays. And so, for example, in my own department in Oxford, we've done a lot of work re-engineering some of our internal processes to ensure that actually, even when we're busy, we can still ensure that there's no significant delays for patients when they arrive in the department, simply by changing the way that we do our business on a day-to-day basis. We've been able to share those processes with other hospitals, and if you look at last year's performance, you can see in the run-up to the winter last year, we had very substantial delays. Clearly the winter period is a time of high demand in terms of acuity, as one would expect. We know that frail elderly patients, for example, are much more likely to need hospital admission during this time frame. But in the run-up to Easter, which again was a period where we were seeing very significant delays, we had another focused effort. And you'll see that from April, May and June of this year, we've seen a significant reduction in avoidable ambulance delays. And that's a very good thing from a patient safety perspective. And I think the challenge for us as we move forward is making sure that this progress is sustained during the winter period. But generally speaking, I found that when hospitals and individual emergency departments recognise that patients who are waiting the ambulance service in the community are actually their patients as well. And actually by working effectively together in partnership, we can substantially reduce this avoidable risk. And clearly the key to success is successful partnership relationships, partnership working, and jointly we can provide a first-class service to our patients, even at times of surges in demand, which do occur at predictable times of year, predictable times of the week, predictable times during the working day. As we move forward, our clinical coordination centres, our clinical contact centres, which are our hub that determine absolutely everything that we do 24 hours a day, is an increasingly important part of our capability. We've taken the opportunity in the last year to refresh our clinical strategy, and we have very significant ambitions as an ambulance service to try and further extend the clinical capability of our contact centres. We recognise that when patients with emergency and urgent care needs contact us, many of those patients are complex, and we need to have a support framework by a range of experienced clinicians to provide decision support, particularly when resources are finite, in order for us to make sure that we get the right resources in a clinically appropriate time frame. At the moment, predominantly the resources that we can send out in a very timely and responsive way are ambulance resources. Where we would like to get to in the next few months, the next few years, in alignment with the KEO review, the Emergency and Urgent Care Review, is that actually we'd like to be able to deliver not only the right care, right time in a clinically appropriate time frame, but we'd also like to be able to dispatch the right clinician to the right patient in a clinically appropriate time frame. And we see real opportunities with further integrating the 999 with the 111 service, underpinned by a range of healthcare providers. We've got a good track record of experience in the last year of having a midwife providing decision support not only to our crews in Hampshire, but they can also help mobilise community midwives to women that wish to deliver their babies in the community, and to do that in a safe and effective way. And we've been able to demonstrate the value of having a midwife, for example, within our contact centres, because that enables us potentially to access their clinical records, their clinical information, advanced care plans, pairing GPs with one of our members of the ambulance service, working in pairs and actually helping GPs assess patients, particularly those who are unwell, particularly those where there may be a need to make complex decision making about how and where care is escalated and whether or not it's clinically appropriate for those patients to be moved. And that's hugely important if we wish to deliver our ambition to support the care of patients closer to their home and not moving those patients unnecessarily into hospital if that's not in their best interest, or even more importantly, if that's not what patients want. Again, we've recognised that the assessment and management of patients with complex needs in residential accommodation and in care homes can be challenging, particularly out of hours, do not have locally employed doctors who may not have good knowledge of those individuals. We've almost completed the rollout of our electronic patient records, which enable us to not only move towards a paperless system, but that tablet PC will enable our frontline staff for the first time to be able to access directly summary care records from GP practices. And so for the first time, they will no longer have to necessarily make big decisions about patients in a relative information vacuum. And that's going to be another key enabler to us to ensure that we are delivering clinically consistent and clinically appropriate care 24 hours a day. We've already touched upon the work we're doing with our mental health colleagues, and again we've had some real success stories, particularly in West Berkshire, of pairing a mental health professional with an ambulance clinician, assessing patients in crisis. Some of those patients, as you would expect, particularly if they're self-harmed, will continue to need care in the emergency department, but a significant number of those patients in a primary mental health crisis need access to mental health care professionals in a clinically appropriate environment. And that pairing has been very successful. In the board, I touched upon the success of the medical student first responder scheme that we've established in Oxford 2 years ago. I'm very much hoping we'll see those schemes rolled out further, not only within South Central, but also nationally. And I also hope that increasing numbers of healthcare professional students will take the opportunity to do some first responding voluntary work for us, because I've got absolutely no doubt that that will improve their effectiveness should that healthcare professional be faced with an unexpected medical emergency during the course of their day-to-day clinical roles. Again, the other sort of elements are our partnership with the Air trustees has moved from strength to strength. Both helicopters are just in the process of being upgraded and replaced, and there will be a formal announcement on this. But this investment will enable us to deliver consultant-delivered care by the roadside for an extended period of time, including night time. That's going to be a new development for the first time. And again, we're also we're further developing the ability to dispatch an experienced emergency physician who's experienced in pre-hospital emergency medicine to provide support to our frontline paramedic staff for those more complex patients, some of whom may require intensive care before they arrive at hospital. And again, this partnership, which is a road-based scheme which complements the air ambulance operations, is likely to pay increasing dividend for our patients. For those of you who are able to join us today for our public board meeting, one heard a very powerful story about Danielle's experience and her experience of major trauma, and her courage and the tremendous progress that she's made throughout the last 12 months of her trauma care and her trauma rehabilitation. And we've already sort of highlighted on the fact that we've now got very high level evidence that demonstrates there's been a very substantial improvement in survival for severely injured patients. And that's a very, very good thing, particularly bearing in mind that it's younger patients on the whole and children who are often unexpectedly injured with potentially lifetime catastrophic consequences. So that is a real success story. And actually this reflects the success of the other clinical networks that we've developed, particularly around stroke care, around cardiac care, and indeed for patients with vascular emergencies. And as those critical clinical networks continue to mature, we're going to continue to see improvements in patient survival. The big challenge for us as we move forward will be making sure that we get care right for patients who need same-day assessment, those with urgent care needs. And we're going to be working very closely in partnership with the new urgent care networks as they become established to ensure that we can signpost and support patients that need consistent access to urgent care. And we plan to develop our own capability within the ambulance service to be able to undertake those urgent care assessments, and when it's complex, to gain decision support, not only from colleagues in primary care, which is absolutely critical, but also directly from colleagues working in secondary care. And that's a very exciting opportunity that we're going to be further developing over the course of the next 5 years. Thank you.
Thank you, George.